Now we've got a slide with a number of different intestinal disorders for you to be aware of. First up is acute mesenteric ischemia, which is a blockage of intestinal blood flow. This can be an embolic occlusion of the SMA, which leads to small bowel necrosis. The typical exam finding is disproportionate abdominal pain to physical exam findings. Patients will complain of extreme pain, like a 10 out of 10, but on physical exam, it doesn't seem to elicit much of a response. Next are adhesions, which are a common result of surgery. They are a fibrous band of scar tissue and are the most common cause of small bowel obstruction. There may be well-demarcated necrotic zones. Next is angiodysplasia. This is where tortuous dilation of blood vessels leads to bleeding. It is common in the cecum, terminal ileum, and ascending colon, and it's found in older patients. You can see one here. Duodenal atresia, which is another disorder associated with Down syndrome. This causes early bilious vomiting, with proximal stomach distension due to failure of recanalization of the small bowel. There is a double bubble sign on imaging, which you can see here. With diseases like these, it is very important to keep track of whether or not the vomiting is bilious or not, because then you'll know if the patient's illness is proximal or distal to the duodenum and the insertion of the biliary system into the GI tract. In this case, vomiting is bilious because the atresia tends to be in the distal duodenum. Ileus is a disruption of the normal peristalsis ability of the GI tract, so there is intestinal hypomotility. It's important that this is defined as being intestinal hypomotility without obstruction. Ischemic colitis here is of a chronic variety. It is, as the name suggests, inflammation of the colon from reduced blood supply. The pain develops after eating, and therefore patients eat less to avoid pain and end up losing weight. The most common locations are at the splenic flexure and the distal colon. Can you remember why this is the most common location? Yes, that's right. This is the watershed area between the regions supplied by the SMA and the IMA. It is more common in the elderly. Meconium ileus is a common presenting sign of cystic fibrosis. What happens is that a meconium plug obstructs the intestine, thus preventing stool passage at birth. Cystic fibrosis affects the CFTR, which regulates sodium and chloride movement across epithelial membranes, including in the intestines. Necrotizing enterocolitis, or NEC, is a major complication in neonates. There is necrosis of the intestinal mucosa and possible perforation. The colon is the most common site, but it can involve the entire GI tract. This is very important disease to know because it affects neonates who have decreased immune systems, and NEC is potentially life-threatening. The classic radiographic sign is pneumatosis coli, which means there is gas in the bowel wall. We'll move now to colonic polyps and then to colorectal cancer. The simple definition of a polyp is a mass that protrudes into the gut lumen, which you can see here and here. They often have a sawtooth appearance on histology. 90% of polyps are actually non-neoplastic, but when found on colonoscopy are removed or biopsied to be certain. They are more common in the rectosigmoid area. The hyperplastic polyp is the most common non-neoplastic polyp, with over 50% found in the rectosigmoid colon. Hamartomatous are non-neoplastic with growths of normal colonic tissue with distorted architecture. It's often associated with Peutz-Jeghers and juvenile polyposis, which we'll cover in a little bit. Now, because colon cancer is an adenocarcinoma, the polyps that are precancerous are the adenomatous polyps. There is a greater risk of malignancy in a larger polyp, one with villous histology. And as epithelial dysplasia increases, this also increases the risk of cancer. A mnemonic you can use is the more villainous the polyp, the more villainous because of its chance to cause cancer. There are various genetic syndromes that can give you a predisposition to colorectal cancer. Familial adenomatous polyposis, or FAP, is an autosomal dominant mutation of the APC gene on chromosome 5q, where colon cancer is assured. Patients have literally thousands of polyps throughout the colon, usually including the rectum. The two-hit hypothesis, in its simplest form, is that one mutated allele is inherited, and sometime during life the other allele is either deleted or mutated, leaving no functional gene. Gardner syndrome is where patients have FAP and also osseous tumors, soft tissue tumors, and congenital hypertrophy of the retinal pigment epithelium. Turcot syndrome includes FAP and malignant brain tumors. To help remember this for the boards, think of a turban wrapping around the head. Turban for Turcot. Juvenile polyps are sporadic lesions in children under 5, and fully 80% are found in the rectum. If there is just one, it's not malignant. On the other hand, when multiple are found and juvenile polyposis syndrome is diagnosed, there is a risk of adenocarcinoma. The Peutz-Jeghers syndrome is an autosomal dominant disease with multiple malignant hamartomas throughout the GI tract. Patients often have hyperpigmented mouth, lips, hands, and genitalia. This genetic disorder has a high risk of colorectal cancer and other visceral malignancies such as pancreatic and breast cancer. Next, let's talk about Lynch syndrome. The genetic cause of colorectal cancer you may be most familiar with is Lynch syndrome, previously known as HNPCC, or hereditary non-polyposis colorectal cancer. This fact is often looked over because the acronym is so catchy. But remember that the name specifically says hereditary non-polyposis, meaning there are no precancerous polyps. Instead, small adenomas in the colon, which are easily overlooked on colonoscopy, can harbor advanced cancers that would usually only manifest in large polyps. Lynch syndrome is autosomal dominant and involves mutations in the DNA mismatch repair genes. What other major type of cancer shows an increased rate in patients with a defective DNA repair enzyme? That's right, it's breast cancer, which is more common in those associated with BRCA1 or 2 mutation. Around 80% progress to CRC, and patients with Lynch syndrome are at high risk for many other types of tumors. The proximal colon is always involved. It can be identified by the 3-2-1 rule, in which 3 relatives with Lynch syndrome-associated cancers can be found across 2 generations, and one of these was diagnosed before age 50. Colorectal cancer is a massive topic of great public health relevance. We'll try to hit some of the high-yield points here. Colorectal cancer, or CRC, is the 3rd most common cancer in the U.S., and also the 3rd most deadly. Most patients are over age 50, and about a quarter have a positive family history. We went over some of the risk factors already: polyps, FAP, Lynch syndrome, and IBD. Some other risk factors are strep bovis infection and tobacco use. The strep bovis connection is so important that if you see a question that includes the words strep bovis, look for answer choices about colorectal cancer or colonoscopy for CRC screening. This is a particularly important fact: the presentation of left-sided versus right-sided colon cancers. Remember that left side obstructs, right side bleeds. Or more specifically, cancers in the distal colon cause obstruction, colicky pain, and hematochezia, whereas cancers in the proximal colon cause dull pain, iron deficiency anemia, and fatigue. Regarding diagnosis, the classic teaching is that iron deficiency anemia in older males is colorectal cancer until proven otherwise. Patients over 50 should get fecal occult blood test and colonoscopy. A barium enema in advanced cases might show apple core lesion. which you can see here. CEA is a tumor marker that is positive in many cases, though not useful for screening. Clinicians often get serial measurements to follow response to treatment, though this has not always been shown to be completely accurate. Okay, let's do a flash quiz. A patient is found to have thousands of polyps on colonoscopy. He has a history of bone and soft tissue tumors. What syndrome is suspected? That's right, it's Gardner syndrome. Remember, Gardner syndrome is an autosomal dominant disease characterized by polyps in the colon with tumors outside the colon, especially osteomas, thyroid cancer, epidermoid cysts, and fibromas. Let's now go through the molecular pathogenesis of colorectal cancer. There are basically two different pathways. Microsatellite instability accounts for only about 15% of cases, while chromosomal instability is implicated in the majority. The microsatellite instability pathway is when DNA mismatch repair genes are mutated, either sporadically or in the Lynch syndrome. The chromosomal pathway involves mutations of APC and beta-catenin. Here we have the standard molecular progression. We start with a normal colon, and when the APC gene is mutated, the colon is now at risk. Loss of APC leads to decreased intercellular adhesion and increased proliferation. Then, if there's a mutation in KRAS, intracellular signal transduction becomes upregulated. This is the point where adenomas form and can be discovered by screening. After APC and KRAS are mutated, the last step is loss of p53. At this point, there is increased tumorigenesis and formation of true carcinoma. Do you remember which genetic disease involves deletion of p53? I'll give you a hint. It leads to development of many different types of cancer at a young age. That's right, it's Li-Fraumeni syndrome.